Hello. Today we have the privilege of speaking with one of the most influential and unconventional thinkers in modern implant dentistry. Professor Stefan Ihde is internationally recognized for his pioneering work in Corticobasal Implantology, known as Strategic Implantology, a treatment concept that has changed traditional approaches and improved oral rehabilitation in complex clinical cases. With decades of clinical experience, extensive research, and thousands of treated patients worldwide, Professor Ihde has dedicated his career to developing biomechanically driven solutions for patients who were previously considered untreatable using conventional implant methods. Beyond his scientific contributions, he is also known for his strong intellectual independence and his commitment to advancing surgical education globally. Today, we will explore not only the scientific foundations of his work, but also the professional journey, challenges, and the vision that have shaped his remarkable career. Professor Ihde, thank you for joining us.
Thanks for having me.
Professor Ihde, you have written numerous books, including a biographical work, as well as the teaching materials for surgeons, prosthetic specialists, technicians. You lecture internationally, continue to develop new implant designs, and are involved in building clinics and training systems. With so many dimensions to your work, how do you see yourself first and foremost? As a surgeon, a scientist, a teacher, or is it something else? How would you define yourself?
Well, first of all, I'm a treatment provider, so I work on patients. This is what I like the most. And I think that should be most important also. Very often I see during treatments some things which are not normal or something I've never seen before. And this, of course, makes me think. And then I can use my scientific skills to find out why it's like this and what needs to be done. But first of all, I'm a treatment provider. I'm an implantologist.
Implantologist. Great. Your last book, The One Who Talks to the Bone, reflects a profound fascination with bone biology. So I'd like to ask about the origin of your thinking. Did your deep study and understanding of bone physiology lead you to create a new implant concept? Or was it the ambition to develop a new implant system that has pushed you to study bone physiology in such a depth?
When I started with the implants, we had osseointegrated implants on the market. And of course, the first thing I learned was how to work with the osseointegrated implants. But the more I was looking into the details of bone physiology and bone mechanics especially, the more I understood that this cannot be it. I mean, this is, to some extent, this osseointegration method works not with the bone, but against the bone. That's why there are so many problems with these implants. And I was then researching into these problems, and that's how I found this immediate loading protocol implant, these implants are very simple to use, and they solved all these problems which the osseointegration method made.
So what brought you to the idea of developing such a technology? Was there a moment of realization, like a true turning point in your academic and professional journey when you decided this was something you had to pursue?
Yeah, the real breakthrough in my thinking about implants happened actually in South America. I was visiting a congress for traumatologists, and there I saw I really had time. I looked at the poster presentations, I listened to the lectures, it was all in English, it was wonderful. And there I understood that what these traumatologists are doing with the implants, this is actually what we should do also. So, I mean, nobody goes for osseointegration in the field of traumatology. Everybody works in immediate functional loading. If you get a fracture plate, it will be loaded automatically. And so this kind of showed me that I'm on the right track with immediate loading protocols, and this took me in this direction.
When was that?
This
How
was
old were you?
2006.
Mm-hmm. So
Yeah, already I was using implants almost 10 years, but these disc implants, and I was just lucky to find these implants first.
But like seeing complex cases that could not be properly treated, that must have been a big role in that decision to start with.
Yes, for sure. The decision to look for other implant designs was very early. This was in the 1990s. And I found the design. I found these disc implants, which were promoted by Professor Stefan from Nice. So he had brought up a technology which allowed immediate loading and which demanded almost no bone. I mean, you need 1.5 millimeters of bone. Everybody has this. So this was let's say, the start point. These were the commercially available implants which I could use, and I used them for 10 years, and then the gradual new developments started.
And how many years did it take before you reached your first positive clinical outcomes?
With the disc implants, they worked. It worked. It was all good. It works from the beginning, and that's why I have cases still under control, which are 30 years in the mouth. These are all cases done with the disc implants or the BOI.
Over all these years, what do you think? Estimate, how many patients have you treated? What is the number of implants that were placed?
Well, in general, I think more than 2 million implants were placed, but not by me. I myself have placed for sure more than 70,000, and this means that approximately 5,000 patients were treated by myself, at least the surgical parts. There are prosthetic doctors who do the rest, who deliver the teeth and so on.
Yes, that's a great number. Congratulations on that.
Yes, that's why I never see my wife, basically.
Professor, can you tell us more about the Implant Foundation, which plays a major role in educating clinicians worldwide? What is its mission?
Well, as this technology is not being taught in traditional universities, we had to find an organization which does the teaching, which also collects the knowledge and keeps the knowledge, and, for example, in journals, in textbooks, and, of course, in the brains of the teachers. So the teachers have to be taught first, and after they are good enough and they have enough experience to be a teacher. I mean, a teacher in medicine, it's a clinical teacher. They teach out of experience also, not only from the textbook. Then the teachers can be sent out to the world, and they are teaching everywhere.
In which countries do you teach?
No, there are a lot of teachers in many countries, but we have teachers who can teach in European Union, of course, in Russia, in these former East Bloc countries, in India, and also in South America, Middle and South America. A lot of teachers are working actually.
So there are many teachers, yes?
Yes, more than 50, maybe more than 60.
And the doctors are being taught, the clinicians, yes? In which way?
No, first they need a basic knowledge. So most of them come to Belgrade to take the course here, actually in this room. And there are local courses, like introduction courses, so the doctors can listen there 1, 2, 3 days to see examples and to discuss and to learn about the differences between the osseointegration method and our method, method which we call osseo-fixation. And then if they are interested more, they come here to this course, 1-week course, and basically they should be ready after this to work on patients. So this is like the step to success.
So what clinical challenges led you to focus on corticobasal implant concept?
The traditional concept, this osseointegration concept, has a number of flaws. So first of all, a lot of bone is required. And the patient, when the patient comes into the clinic, he has to have a lot of bone, simply. And if there's no bone, then bone augmentation or bone transplants are being done. And of course, nobody wants this. Nobody wants this because it's painful. There is some donor site where the bone has to be taken. And I mean, there are a lot of risks associated to this, also costs, and of course, healing times, waiting times. So this was something that I never wanted to do. And I have to say also, when I started with the implants, the bone augmentation was not yet invented. So I was lucky that I had to find a solution which works without bone augmentation, because it was unknown. Nobody did this. So that's why I focused so much on the disc implants, on the BOI implants, first of all, because these implants didn't need bone. And as a extra, these implants were used in immediate functional loading. So I never believed, all my life, I never believed that the healing time is necessary. This is the other point.
So that would be the biggest difference comparing to traditional concept. But in simpler words, what it offers to patients comparing to traditional methods.
Well, what we can offer today with the technology as it is used today is immediate functional loading. So the patients come, we remove the teeth, we put the implants, and then we don't wait for the bones healing, but we wait for the dentist technician to give us the bridge. So immediate loading means that in 2, 3, maximum 4 days, the whole thing is done. Patient can go home and they can eat on their implants. This is the biggest difference, and this is not available with the osseointegration method. The second point is that we can work with all bone conditions, so even with very atrophied or very much shrunken away bones, and we can nevertheless work in immediate functional loading, and we give fixed teeth. Usually we give fixed teeth. We don't do like bars and dentures, we give fixed teeth.
Many patients don't understand the difference between cortical bone and the spongy bone. In simple terms, why is cortical bone such a good foundation and important foundation for this implant concept?
Cortical bone is highly mineralized, so it's like a strong piece of wood. Whatever you screw in there, it stays. In simple words. So, of course, I always wanted to use the cortical bone for my implant because it's more reliable and it's done actually. So in the osseointegration procedure, the bone has to grow actively onto the surface of the implants with the help of God. And if it doesn't happen, the implant will be a failure. But if I can screw the implant, or in the old times, like hammer these horizontal implants into the cortical bone, it's done. I make the integration, and I can feel it. I can measure the torque. It's a very well controlled process, and I'm the one who controls it.
For many patients, it may seem surprising that the implants can be loaded immediately. Could you explain simply why immediate loading is actually part of the success of this type of implant and not a risk?
Yes, the loading is of course important, because if we put an implant into the bone, we motivate the bone to what we call remodeling. So this is a restructuring process. Actually, the Russian translation of this word remodeling is perestroika. Maybe you have heard this word before. So it's remodeled, and the direction for the remodeling is of course given by the forces which come from the chewing into the bone. So an unloaded healing time makes no sense to me at all. I don't understand how somebody can do this, because you put the implant in, it is not loaded. So how should the bone know where to heal and in which direction to heal? This is the big problem of this technology of osseointegration. So we give the loads right away, the real loads, enough loads. We put a few more implants so that we are sure it's going to be stable. But then we are loading, and the bone can heal from day one in the correct direction.
In one of your lectures, we heard you mention that in some cases, bone can regenerate after implant placement. Can you explain this phenomenon? How is this even possible?
Well, if you extract a tooth, let's say a normal tooth without periodontal disease around it, then the socket, the empty socket, will be filled with the woven bone, and later it will be covered also by cortical bone. So whenever you take out a tooth, to a large extent, the bone, the shape of the bone is coming back, let's say. Okay, so it's always a little bit less after each extraction, but it comes back. And even in almost crazy cases where big pockets are there, and periodontal disease is really in the final stage, or there's a big hole in the bone. If you put an implant directly into the socket, the bone will regenerate. I'm showing you this on the example here. So this is a patient who received in the lower left jaw an implant after the extraction of this very much infected tooth. And as you see, 2 years later, the bone has filled up again. This works by itself. There's no bone augmentation. You don't see any bone augmentation here.
Professor, which patient profiles particularly benefit for this kind of approach?
We have a lot of patients which have been treated before with osseointegrated implants, and these implants, after a few years, start ailing, failing, making problems, starting to be in a chronic infection. And we have the possibility to remove these implants and just put our new implants inside and put the bridge, so this will heal very nicely. So this is, let's say, a big market. There's so many osseointegrated implants are put into the jaws, especially in Europe. It's a big market to take them out and to change them finally for implants which can last forever. I mean, there's a big difference between osseointegrated and ossifixated implants. The next group of patients which has problem to find implant treatment are the smokers, especially these heavy smokers, because they cannot get the bone augmentation. If you want to go for osseointegration, you need the bone augmentation first. And in the smokers, the healing of the soft tissue above the bone augmentation is very doubtful. So there are a lot of losses, maybe 30% losses, so that most implantologists don't want to treat smokers anymore. For us, it doesn't matter. We don't make a flap anyway. We just put the implant in, and this heals just as any other patients. Yeah, the next important point, I would say, are the contraindications for treatment with the method of osseointegration. So this older method has a long list. I think it's 35 contraindications where you cannot do it. And the list for ossifixated implant, for our implants, has exactly 5 contraindications where we cannot do it. So it's much more applicable. Basically, everybody who comes into the door can be treated. You know? So this, I mean, there's a big difference between that. I see also that some patients who have been told that they have a lot of medical contraindications, or like hypertension, diabetes, and whatever they have. I mean, everybody collects during life more and more contraindications. So basically, the older patient, everybody has 10 contraindications out of these 35. But for us, it doesn't matter. We can always put our implants. For these implants, there's completely different demand on health of the patient. So I mean, the patient, of course, must be, from the heart point of view, we're healthy enough to survive the implant placement, but basically everybody is this. So there are big differences, and the applicability of our technology is much wider. So I would say, also looking always at the university, if a university should teach implants, I think they have to teach our implants, because if the doctor knows to do that, he can go out in the world and treat everybody. Not only a small group of healthy elderly people with no contraindications.
I can only imagine what it means for a patient, for example, that hasn't have his teeth for 10, 20 years, that he gets a fixed solution in just a couple of days. It must be a life-changing. It's a very a huge psychological impact.
Yes, of course, the patients are very happy. On the other hand, if patients get early full dentures in upper lower jaw, they are more or less used to this after I don't know, 10, 20 years. So the majority of our patient comes actually with a lot of very doubtful teeth in their mouth. So very often we have to extract all teeth. We take out 24 teeth or 28 teeth, and then we put the implant. These patients have understood that working on these implants, or to try to improve the situation on the teeth, it's impossible. So not to invest money into the teeth anymore, simply take them out. And we do this. Most dentists don't do this. The dentist always will tell the patient, look, we fix here, and after this we fix that, and fix here and there and upper and so on. And patient always is hoping it gets better, but it doesn't get better. The more often you fix the same tooth, the worse it gets. But this nobody tells.
And what is the approximate time for full recovery and adaptation? They get their teeth in, let's say, maximum a week. Yes. From the first day until the last one.
3-4 days. Mm-hmm.
Yes. Mm-hmm. So what is the time for recovery required?
You mean the bone or the patient? Look, with the bone, it's like this. Whenever you operate on bone, when you extract the tooth or you put an implant, it doesn't matter. Whenever you do surgery on the bone, the time to adaptation and consolidation, also this for this remodeling, is up to 2 years. Okay, but this happens deep in the jaw bones, or it happens in any other bones which have been operated. And the patient doesn't notice this. There's no pain connected to this. The bone doesn't have any nerves which can transmit information from the bone. There are nerves going through, for example, here from the lip. But bone has no nerve. So bone is kind of a self-repairing tissue. It is very effective. Bone in the repair, the bone never makes any problem, never makes any mistakes. So whatever the bone does is right. But bone can't cheat. That's, to bring it into one word, and that's a big advantage, of course. There will be always healing. Patient doesn't notice it. The other question is, if we are extracting teeth, when are the patients not going to feel anything? I would say after a week or 10 days or 2 weeks. I mean, even the most sensitive patients, after 2 weeks, they feel nothing. Most patients don't have pain on the day after the surgery. For example, we ask the patient on the day after surgery how many pain tablets they took. We ask them this as a routine. And around 70% of the patients don't take any pain tablets on the day after the surgery. So that's basically an acceptable amount of pain and discomfort.
So basically, for a patient that comes for the surgery, he can go back to everyday life in a week.
Yes. Yeah, the local patients here, they leave the surgery and go to work here in Belgrade.
Yes, that is a life-changing for sure.
Yes. Because they go to work because they want to think about it. They want to do something and they are needed at the job.
Professor, so to go more deeply into scientific evidence and long-term performance, what studies or long-term clinical results show that this type of implant remains stable and reliable over time?
There are a number of studies which were published so far. I think the first one appeared 2019. This was a 4 or 5 years study. Then in the 2020s also studies appeared, and in 2024 we have published for the first time our study from the clinic here in Belgrade and the clinic in Montenegro. This is, to my knowledge, the biggest study which was ever published in oral implantology. So we were looking up to 12 years back on 17,000 implants. And these 17,000 implants were placed in 915 patients. Mainly, most of the implants were placed in upper and lower jaw, so the patient got a full mouth reconstruction. Some of the patients got a single jaw reconstruction in upper jaw or in lower jaw. And the success rate was enormous. I was shocked myself that even the best studies which I found from the field of two-stage implantology were compared to these studies, we were 3 times better. So we had a loss rate of around 1%, and we had 94% of successful and healthy cases. So the successful and healthy, these are 2 parameters which have to be looked at. For example, if an implant has an infection, but it's still in and stable, and patient is chewing on it, so it's a successful implant, but it's not healthy. And we had a rate of successful and healthy of 94%, and there were a few cases. 1% was lost, so around 5% of the 4.5% of the cases which were for the moment, we were not 100% sure that it's successful and healthy. So we just put this into, but we didn't do nothing. We sent the patient home and says, come after 1 year, we have to see this case again, then we will decide if something needs to be done. So I think this is a dramatically good result. And as I said before, I'm looking at patients now with almost 30 years of implants in their mouth. So I'm sure that these implants can last forever. Also, integrated implants cannot last forever.
And over all these years, your system has certainly evolved. What major improvements or developments you introduced over time, and what problems were those innovations designed to solve?
Yeah, as I said before, we started with a disc implant design. So these BOI implants, these horizontal plates which were put into the bone. So basically, this was a system which came from France, and it was already working when there was nothing to change. We later did improvements to those implants, but shapes were improved, lengthy implants were created, and so on. But in those 10 years when I was using these implants, we worked always an immediate functional loading. The implants were polished. The diameter, this mucosa penetration diameter, which, this little hole where this goes through the skin in the mouth, was 2 millimeters. So it basically, I'm using this type of implants almost 30 years. Let's say the big switch started 2006 when we used the screwable basal implants. So the implants which have a thread and which is then engaged in the second cortical. So, for example, down here in this cortical. And the advantage of this development was that the surgery was faster. So in an edentulous jaw, when the patient has no teeth at all, so to put these, let's say, 10, 12 implants in the upper jaw is a matter of 15 minutes. And we give the injection, then we put the implants, and the patient doesn't even believe it's done. So I'm just going out. And this is, of course, super that we can treat so many patients in so short time from surgical point of view. This, of course, makes it cheaper for the patient because we can treat more patients in shorter time.
Professor, you manage the foundation. We were mentioning you manage clinics, you manage production of implants. How do you find the energy and time for this?
Well, I can't do this all alone. So the Implant Foundation is run by professional people, and it is supervised from the method point of view, also by my wife. She helps me a lot. The company is run also by a manager. We just met him, Mr. Fischer. So he does this, and he is very good in this. I mean, he really brings this company up. That's very nice, and it's in safe hands. So I don't have to take care too much. I'm advising him a little bit from, let's say, dentist point of view, but basically he has to do it, and he is trained for this. Writing the books, I mean, this can be done in the morning or in the evening. And, the article, it's the same. Simply if you get up early, the day is long and a lot of things can be done. I think this is the main answer.
So do you have to travel a lot?
Not anymore. I started traveling in around 2004 or 5, and I traveled more or less for 20 years. Then when this pandemic started, I was stopped, and I got used to not to travel so much. So then it became less. Now I have more time for writing. But on the other hand, you see, even if I fly to India, which is a long trip, but I can sit there, nobody calls me, and I can write. I can write books, articles, stuff like this. So this traveling is not really prohibiting me from working.
So you're not sparing your time, for sure.
Yeah, what to do is anyway boring,
Which countries do you travel the most?
Well, South America, India, Russia, and of course European countries, Bulgaria and so on, Germany. We don't. We are not distributing these implants in the United States. But I mean, I always refused because this system is unreliable, I would say. The Americans are crazy. I mean, we see this every day now, right?
Yeah, for sure.
I was sure 20 years ago already.
Ihde Dental is the mark of your implants. Is the production of these implants a big challenge for you?
Oh, no. No, I don't have a lot to do with that. It's automatically done. I mean, we have supplies of the raw implants, and then the production takes place in Switzerland on our machines. And this is, I mean, creating the final product. This is what we are doing. Now we just opened a new small company for making the raw implants also. So this will be integrated also. It's step by step. We're doing this. I mean, we started with producing implants 1997 or 8. This is when the CE marking came up, and since then we always improved. We always added stuff into the production, and except the sterilization, we can nowadays do everything.
Where does the production take place at?
In Switzerland.
You've been working with Anveli for a long time already. What do you think? How many patients were in that collaboration were treated? And for how long is the collaboration?
We worked together around 10 years, I would say. This is rather the question for Professor Ihde to run the clinic. And we get patients here in Serbia and in Montenegro. And we also got patients to the Swiss clinic. So how many patients were treated, I have to admit, I don't know. I mean, for sure, more than 1,000.
That is a quite number, yeah. Patients from all over the world, I suppose, yeah.
Yeah, mainly French-speaking patients from French-speaking countries, but more and more also Germans. And I mean, this spreads. Huh?
So people enjoy traveling to visit you and have you there as their surgeon.
Yes, but this technology, unfortunately, is not available all over the world and not in every town. And I mean, we are far away from that. So this is a technology which can be spread only with the dental tourism. You know, what is dental tourism? I have treated more than 100 doctors, for example, in Hungary. In Hungary, they get a lot of dental tourism from the Austrians, from the Germans, even from Swiss patients. So they are tuned for this. So they I mean, sometimes the clinic have their own hotel, and they just do this from the morning to the evening. And of course, for these clinics who work in dental tourism, this is a big step forward to work with this technology, because the implant patients don't have to do 2 times or 3 times until the implant is in, but they come one time, they get the implants, the bridge, and they go home and they are done. They only come for the control or get the control done somewhere else. This is a big advantage. So this actually, our technology is a product for dental tourism. You know, for management clinics who run such clinics, and if they look for such a product, I mean, our technology is ideal.
Nowadays, everything is so much easy approachable. Yeah, all the cities that you work in, and the patients can fly over very easily. And like you said, if they stay for they have a one visit only, it's a huge benefit and advantage, as you said.
Yeah, so it's. I mean, people are likely to do this. Patients are likely to do this if they understand that they're really going to be treated. After a few days, they have to go only one time, no healing time. I mean, healing time means no teeth in the mouth. Right? In reality, it's not that the healing takes place is the problem, but the teeth are missing. So, I mean, this is not difficult to sell.
So basically, Anveli has their patient care team that is taking care of all the rest while you are the main person for surgeries, if I understood correctly.
Yeah, me and of course the prosthetic doctors. I mean,
yes, of course.
I'm not the main guy. I'm the one who goes home first because I do the surgery and that's it. Then I can go.
but so everything else depends on you, yes?
Well, the surgery depends on me, but let's say the success of everything depends on the team. And Anveli is an important part of the team because also they know a lot about the patients. They send a lot of panoramic pictures to give an estimation what can be done, or we advise them regarding sicknesses of the patients. Also, there's a very good communication with Anveli.
So that's why everything is actually working to a perfection. Yes, from the beginning until the end, and the patients must be happy.
Yes, they are happy, and they're also reminded to come to the controls, which I find super. And we don't have to employ staff who does it, because anyway, patient needs to be reminded for controls. Not everybody is so reliable.
I won't go deep into that if they are coming back for controls.
Yeah, they come. Yeah. When we did this big study with the 17,000 implants, we saw that I mean the rate of the patients which were not available, and we had a 15-month period where we wanted, I mean, which we the start and the end. This was 15 months, and all patients which appeared in this period, or which have been interviewed by our interviewers, or which have sent a panoramic picture, counted then as as with it being with the implants, or everything is okay or not okay, depends what they said. And we had about 23% of the implants which could not be found anymore. Well, of course, some are dead, but most of them are simply didn't pick the phone, or they moved or changed the name and location, email address. But this is normal for a 12-year study. No, things happen. Things are moving. People are moving.
Yes. Digitalization also takes a big place in dentistry. Mm-hmm. Do you use it in your protocols as well?
Mm-hmm. Yes, we can take regular impressions, or we have digital impression. It depends a little bit on the case. But in the dental lab, after the impression, the rest of the work is always done digital. Oh, except of course the try-in. So if this temporary bridge is ready, we have to try it in the patient mouth, and then we have to determine which changes are necessary. If the tooth arch goes more up or more down, or the teeth, something like this. So this is a manual job. This we cannot do digital. But then after the aesthetic and the position of the teeth and the chewing situation is clear and controlled during the try-in, then this goes again to the digital production. And then, of course, because we work with the zirconium, everything is digitally produced. It's automatically milled and then sent.
So then just final touches.
Final touches, yes, of course, aesthetic, the color. For this we need specialists who really see, what does it look like, and this we cannot digitalize, I don't believe. I mean, we could, but it would be a very, very standard result. It's not beauty. This is not what patients expect. So we have like artists, actually. They are dentist technicians, but they are more artists. So they run the machine and they put this feeling into the work.
Yes, it has to be an individual approach to every patient.
Yes.
Yeah. What are the next developments that you can predict in this kind of implantology and dentistry in general? Maybe regarding this artificial intelligence that takes place now more and more than ever.
Well, in our field, I'm not so sure if artificial intelligence can do a lot more. Also, I think we have to be a little bit careful with artificial intelligence, because this type of intelligence is not intelligent. You can train it and to tell the wrong things, and then this intelligence will learn the wrong things and will continue telling it. So there's no really. I mean, it needs control by intelligent people. I don't see this happening.
Real intelligent people.
Yes. But you need to have some knowledge to understand if what the computer tells you is true or not. I mean, if you just take everything as it's written there, you end up nowhere. And this is unfortunate. I mean, I work a lot with this, and I'm shocked sometimes what the computer thinks is true.
And it also ends personal improvement and way of thinking. People rely most in what they read. They just don't use their brain cells as they should.
Yeah, especially the children don't get educated as we got. Don't have to learn so hard.
You have lived an extra ordinary life. It seems that you never take time for rest and time off. What is the reason for this large effort you make?
Well, I would say it's in my upbringing. So my parents had a family business, and I grew up in there. And my mother told me often that I started to work or help or do something when I was 5. So I'm used to work a lot since, I mean, really from young age. And actually, this business is the same business that I'm running. This Ihde dental business. So it's now 70 something years old, 72 or 3 years. And let's say I'm now 64 if I start with 5, like my mother told me, and I believe it. I mean, then I work in this business now 59 years. So there was always enough work. I never had to complain about that. So it kept me busy.
Wow, that is amazing, yeah? So your family business taught you and brought you into this field.
Well, we started the production of implants 1998. Before this, we were selling filling materials and so on. We still sell it today, no question, but this is when the implant development started. I also, I forgot to mention this, I also was very lucky that we had the production of the metallic implants. I was lucky to meet somebody, and we became good friends over the years. And then we opened the company together to make the metallic implant. So every little change that I needed, in 2-3 weeks, the implant was on the table. It was there. So this fast supply of new ideas was, of course, super for the development.
What achievements are you most proud of in your career?
successful patients, I would say. I mean, they are the most important. So there are cases now close to 30 years with the implants. And I really have to admit, I mean, this makes me proud. This makes me very happy. Just last week, there was a patient which was operated in Switzerland actually in the last century. And he came after 25 or 6 years to change the bridge and to take the remaining teeth out to complete the upper arch with implants. And I mean, look, it's like this. When I first treated him in probably 99, I took the teeth out, I put some implants, and then I made a big bridge on the implants and the teeth. Okay, so he was maybe in the treatment 3 days. Then he was 25 years not at the dentist. And then he came back. No, of course, what should the dentist do? And then he came back. Okay, after 25 years, you had to take out all the rest of the teeth. He is now 88. I mean, I don't think he can complain. We put implants and gave him the bridge back on day 3. So basically, he was 6 days under treatment, and 25 years of his life passed. So I think this makes me proud. So this tells me I was always on the right path with the immediate loading, with the polished implants, not to use osseointegration method. So, yeah.
This is the result and reassurance. You're doing things right.
Exactly.
Yeah. And what legacy would you like to leave for future generations of clinicians?
This method is available. They can learn it. Nowadays, everything is clear. When I started, there was no Stefan Ihde behind me telling me what to do. But today, this guy exists. And here in the course in Belgrade, we guide everybody on the right path. You know, we answer all the questions. I mean, it's not only me, but the other professors also. And the legacy, I don't know if this is needed. But what I can say is that the knowledge is there. The knowledge comes in little pieces. It's easy to digest and to learn. And I think this will remain available.
Professor, to conclude this conversation, what is the message you would like to give and share to patients worldwide?
Patients are told by the treatment providers to repair the teeth, let's say whatever it costs. So not to become toothless and always to invest early enough so that the teeth can be preserved. The reality is that you cannot preserve the teeth. This is a very small amount of the population that dies with their own teeth. And so the patients should be aware that the possibilities of dentistry are limited. And they're much more limited than the dentists are going to tell. So the patient, by himself or herself, has to decide that this is it. I will not invest in my teeth anymore. And better to decide this earlier than later. Because as this example shows of patients who are 25, 30 years equipped with implants, who never went to the dentist in those years, what more do you want? And they have fixed teeth, it looks good, everything is okay. So this is what I advise to the patient. Don't trust too much in the dentist, because in English we say to a man with a hammer, everything looks like a nail. So, the dentist sees the tooth, he will repair it. And the second part of the question, what to advise to the young colleagues when they come from, for example, from university, or when they're starting their life as dentist or treatment provider. Well, my advice is go for this modern method of implantologists, because there are a lot of good people are needed, and they have a lot of work, and it's a nice income. And everybody can be a dentist with this diploma hanging on the wall, but to be a good implantologist, this is a much higher level of patient treatment, because there you have to create, you have to make the best out of a very bad situation. You have to know about the bone, and there are a lot of specialties they have to learn. But I think it's worthwhile to learn this and to put implants. It's much more worthwhile than to work like Sisyphus, who's always pushing the stone up the hill, and when he's on the top, the stone always falls down. So the repair of teeth is Sisyphus work. It's simply, we know, I treat the teeth, I put the filling, and I know if I'm only living long enough, I will do it another 3 times with the same tooth. So what is this? This is not a life, right?
Professor, the all-in-one week. What is this all about? Can you tell me more about it?
Well, All in One Week is a course which takes place here in Belgrade, actually in this lecture room. The doctors come from all these countries which I've mentioned before, and they get teaching in this immediate loading implantology, in Corticobasal implantology, and all these things around bone physiology, changes in morphology, general information about doing surgery and treating infections and to find out if we can treat the patient and so on. And of course, a big part of this course is going to be about the prosthetic work and also about how to cooperate with the dentist technician. So basically, in this 1 week, we have around 62 hours of teaching. I mean, this is not something for lazy guys. So they really have to be committed to learn this as fast as possible. And then they can go home and they can treat patients. Of course, a little bit under supervision, so they should always have somebody to talk to. So a lot of colleagues write WhatsApp to me and send cases before and after surgery, and I advise them what to change. So, but slowly, they are more and more standing on their own feet, and they know what to do. And for this, they need the course. Without this course, I don't see future for somebody to just start.
So, who qualifies to be able to enroll the course?
Well, they must be dentists. They have an active license, so they can work. Doesn't matter if they are dentists or surgeons or maxillofacial surgeons, but basically they must be in this profession. Everybody qualifies, even somebody fresh from university.
So they don't have to have previous experience in working for amount of years.
No, but I mean it's not bad if they have experience. If they have experience with prosthetic work, with finding the planes and all aesthetics and so on, this is not a disadvantage. The disadvantage is if somebody has learned about the osseointegrated implants, because there the rules are so much different. Those doctors who unfortunately have been in contact with the osseointegrated implants and learned those rules, is very difficult to convert them for real implantology.
And how many clinicians can be enrolled in one course?
We have here 8 seats, and sometimes there are some sitting in the back row. So I think 12 is the maximum. Yeah. Also for the professors, for us, it's. I mean, we want that everybody is awake, and we ask questions, and we kind of try to make it a little bit vivid. So then, and it's enough. 12 is enough. 8 is ideal.
Professor, thank you so much for your time and this insightful conversation. It was a great honor and pleasure talking to you today. Thank you.
Thanks for having me. Thanks for coming. Thanks for all these questions, your patience, and the motivation which you gave to me to answer in such depth. Thank you very much.
You're welcome, and thank you again.